So it has been described as the paradox of health in our time. The fact that statistically we are healthier than ever before. Life expectancy is longer than ever before. And still health is more and more unevenly distributed. If not between countries, then within countries, between people who might be neighbors, who might be living in the same city. How can we explain this paradox, and what can we do about it? How can the universal right to health become available to all people on the planet, in every country, in every neighborhood? It is a great privilege for me to host this panel with three people who I think are excellently well placed to try to give some answers to these questions. We have to start with an excellent representative of the regional and local level, Margareta Kristensson, who is a professor in social and preventive medicine here at the University of Linköping, who was the chair of the Östgötakommissionen, a commission to look at equal distribution of health in this region, and who's also part of the Swedish Commission on Social Determinants of Health. We will be joined shortly by the Swedish minister responsible for these issues, Minister for Social Affairs, Lena Hallengren, who, as I said, is traveling here by train. So we will have the national perspective as well, and the political perspective. I think it's important to ask ourselves, what does people in power do? What could they do about these issues? And last but not least, we will be joined again on this stage by Sir Michael Marmot, who is a research professor of epidemiology, look at this, and public health at the University College of London, and former chair of the WHO Commission on Social Determinants of Health that released its final report 10 years ago. We will ask Michael to let us know what's happened in the last 10 years and what can be done further on. Please give the two of them here, and also Lena in her absence, a warm welcome. So we do have an excellent panel, but we do also have a very complex topic. I have asked the three panelists to try to be as short and spicy as possible, to cram as much information and knowledge and insights into each intervention as possible for you to get the most out of this session. We will leave a little time at the end for your questions. If possible, if you can prepare them in writing, we have people who can collect them. Josette is here who can help collect questions. So send her a note and we will take as many questions as possible at the end. We will, as I said, go from the global to the local, and we will ask Michael Marmot to start. Please, Michael, join me here on stage. A warm welcome.
Two years ago, 2.5 years ago, you will have read in your newspapers that Grenfell Tower in London went up in flames. 72 people died, all poor. We have lots of high-rise accommodation in London. It wasn't high-rise flats housing rich people that went up in smoke. It was high-rise accommodation housing poor people that went up in smoke, and 72 people died. Parenthetically, a Conservative cabinet minister last week said, well, if they'd had any common sense, they would have ignored the advice from the fire service. I would have, he said. It's hard to be sober about such a comment, that the 72 people died was somehow responsible. It wasn't the poor quality of building or anything else. Now, that's an acute tragedy of inequality. In a way, a more important but less obvious tragedy, when the Grenfell Tower occurred, I looked up the health statistics. In the Royal Borough of Kensington and Chelsea, where Grenfell Tower is, in the area around Grenfell Tower, if you compare that with the rich part of the borough, there's a 14-year gap in life expectancy. I don't know if I should confess to this, I went to a dinner at the residence of the ambassador of Thailand in the south part, the rich part of the borough, and you could see the charred hulk of Grenfell Tower. You could walk from one to the other in a fairly short time, and the gap's 14 years in life expectancy. I'm supposed to be talking about the global picture, but the global and the local are linked. I think you could say that what Grenfell Tower illustrates and what the life expectancy gap, comparing the area around Grenfell with the rich part of one London borough, illustrate, is that we've not been doing very much nationally in Britain. It looks like perhaps we've been ignoring the kinds of things that I said in the WHO Commission. But it's not as bleak as that. After an appearance on the BBC, a BBC journalist said to me, we were having dinner afterwards, and he said, "You're a professional optimist, aren't you?" I said, "Of course." Suppose, I said, there were only 8 countries that had listened to the advice of the WHO Commission. I'm not going to go around the world saying that 184 countries are ignoring me and only 8 are listening. I'm going to go around the world saying, look at these 8 countries, they're doing it. Next month it might be 10, and 3 months after that it might be 12. In fact, it's more than 8. I was asked, as you heard this morning, in the wake of the WHO Global Commission, to chair the European review of social determinants and the health divide in Europe. I chaired an English review, so in the wake of the Global Commission, I was asked by the British government, how could we apply your recommendations and findings for one country? In fact, I remember it well because I had just fallen off my bicycle and fractured my femur. The first time I traveled after that painful event, I came to Stockholm in January 2013. And at the meeting, a Swedish parliamentarian said to me, the half-life of most commission reports is about 6 weeks. You produce a commission, I'm sure it wasn't true of your report, but you produce a report and half of them are gone within 6 weeks. He said, your report is still being discussed by the Swedish Parliament 5 years later. He said, next time you come to Stockholm, come and meet the Social Committee of the Swedish Parliament. So I did. This was 2013. Just in time for the... so I went and met the Social Committee of the Swedish Parliament in 2013, and I said, yesterday I was addressing, is it called SALA, the Swedish Association of Local Authorities and Regions, and there were 280 people representing local areas all over Sweden. And I said to these parliamentarians, the level of enthusiasm in that room was palpable. I was talking about what I do, social determinants and health equity, and they're all saying, we want to change. Now, this is Sweden. One of my colleagues in London says, you're not going to Sweden again, are you? Why don't you go to Addis Ababa? They don't need to hear you in Sweden. They need to hear you in Ethiopia. But it's interesting. Sweden looks terrific to everybody else, but to you, it doesn't look as good. And they're both true. Sweden is terrific, but there's much more that you can do. So I said to the parliamentarians, if every local authority in Sweden is taking action on social determinants of health and you're doing nothing, you're going to be left behind. I'm delighted that you are discussing my report. I'd be even more pleased if you did something about it. Well, as you know, I don't want to get into local politics, but one thing led to another, and there was indeed a Swedish commission. And there's been a lot of action at local level. And when I look globally, I can see that picture reproduced. I reported this morning from the Commission on Equity and Health Inequalities in the Americas. Now, one needs to be careful here because it looks like, well, we did this global commission. We said social injustice is killing on a grand scale, and we called it Closing the Gap in a Generation. And it's easy to think, well, we've made progress if one region does a commission or a city does a commission. There's a danger of an infinite regress. If the indicator of progress is somebody else producing a report, that's not very compelling. What we want are real indicators of change. But we're seeing changes. And as I mentioned, I'm next week kicking off as leading the new commission in the Eastern Mediterranean region of WHO. So there's a great deal of interest. And where we don't get action at national level, so in the UK, not much has happened at national level over the last decade. We're getting action at the city level, just like you're doing in Sweden. Excuse me, my back. Just like you're doing in Sweden. The city of Coventry declared itself a Marmot city. Manchester, Greater Manchester, declared itself a Marmot region. I did say to the chief executive, my wife asks if you could call it something else, please. And the chief executive says, sorry, that's through the system. I asked, could you write to my wife and explain, make it easier. We're getting action in Costa Rica. The Minister of Health said, we want to take action at city level. Brazil, the government is, I don't want to say too much about the national government at the moment, but they're really active in cities, in regions, and districts, and saying, what can we do? So just as I said to the BBC interviewer, I am a professional optimist. I see signs of uptake all over. But there are two key components to closing the gap in a generation. One is the evidence of what we can do, absolutely vital. But the other relates to what we put on the cover of the Commission report. Social injustice is killing on a grand scale. You've got to want to do it. And you've got to want to do it in a spirit of social justice, because it is the right thing to do.
Thank you so much, Martin. Please take the seat, Michael. Can I just ask you before I hand over to Margareta, and you can take your place there with your slides. In your report, you highlight the issues of power. You're saying that one of the most important determinants of health is also having power over your own life, deciding if you're a woman, if to have children, how many children to have, having the power over your working conditions, indeed having the power over your health. Having access to health, but also the power to tell what you need and the purchasing power for the medications. How do you deal with these power relations? Is this still a very relevant issue to talk about?
Oh, it's highly relevant. At one level, we take education of women. That's one route, not the sole route, but it's one route to power. We know from surveys in low-income countries that a distressingly high proportion of women say that it's acceptable for a husband to beat his wife if she refuses to have sex with him. It's horrendous. But the more educated the woman, the far less likely is she to endorse that proposition. Now, whether that's because her husband's educated or because... We know that women participating in conditional cash transfer schemes who have support of other women are far less likely to be victims of intimate partner violence. So you can see that educating women, women being economically self-sufficient, women being supported by other women, are all routes to empowerment. And then at a macro level, I know where you work. I showed this morning what's happened to income inequality, for example, in the United States. That fairly closely parallels the decline in union membership, so that there's a shift in power from workers to the owners of capital. And that shift in power relates to a shift in economic resources. So inequities of power can happen at the family level, between boys and girls, men and women. It can happen at the community level, and it can happen at much broader level. And we've talked about in our American report about the unequal power relations between countries in the Americas. So it can happen at that supranational level as well. Right. So it's highly relevant.
Thank you so much for this. Margareta, the floor is yours for a regional perspective, please.
I wanted to start with a piece of national perspective, because some of you who sit here and when you have listened to Michael this morning and seen all the pictures of social differences in health in the States and in developing countries and in England, it couldn't be that in Sweden. We have lived with a picture that we do not have inequalities in health. I grew up with a picture that we don't have inequalities in health. And many still believe that. And actually, my understanding was almost right, because for a long time we had very small differences in health. But as you see on this picture, we have, since the last 30 years, widening inequalities in health. This is about life expectancy at 30 years of age, and that is to take away death rates for children, and it could have been exactly the same without that. Today, those of you who are 30 years old, your friends who stop school before their gymnasium, you will live 6 years more than them. Not because you will be 106 and they will be 100, but because they will die in middle age, in coronary heart disease, in cancer, etc. And for a period, and I heard that from pupils, if you look at until 2006, it's parallel. So what's the matter? Everybody lives longer, and if they live a bit less longer, would that be a problem? Yes, it is, but it's also so that you can see that it's now declining. So the development for the poorest, and this is about education because that is the most easy to have. The differences in health today in Sweden are stronger for income. And those with lowest educational status, their health development has stagnated. And for the lowest group, it's coming down. And we tend to be 30 years after the States. And what Michael showed this morning, that you have declining life expectancy in the poorest groups. So these are important things. And when we started the Östgöta Commission, we had the objective to firstly see if there are any inequalities in Östergötland. And most politicians, they actually did not expect that. Not in our cozy, nice county. We couldn't have that. And then when it found that this was the same also here, there was an interestingly broad commitment from left to right that this is not acceptable. Do something. Then we have the discussion, is it, some would say, well, we cannot mend the life for people. People need to take responsibility for their lives. We can't do everything, or? And that tends to polarize political discussions. So we made this picture, let's go see that. This one, which is a picture from the A level in public health sciences, which says that, of course, I as a Indian always have a responsibility for my health. But all of us, all of you, who can help people on their life circumstances, because we have very deep levels of the hill to climb. Can you see that? Our objective is to make that as easy as possible. I have had criticism that he looks happy. He should look worried because it's about health. But it's good, it's about life, living life, and it's good to have life. Based on that, we developed this model, where we have developed the model by Dahlgren and Whitehead, a classical model, to show that the basic influence is the societal development on social, economic, and ecological sustainability, which then affects what Michael used to say, the places where people grow, live, work, love, and die. And that is housing, neighborhood, cultural activities, work, schools, and also health services, which then decide what kind of education, occupation, etc., which I can have, which has effect on our lifestyles, our social environment. And then earlier, models stopped there because, and I have asked, why don't you have psychological factors here? And then they have said to me, this is for politicians, and politicians cannot affect hope for the future. And our politicians said, yes, we can. And so we included this inner circle about confidence in our own ability, trust in others, and hope for the future. And as a physician interested in why people die from these issues, I wanted to have a circle also on physiology. And Annika over there said no. And that's why we have a red heart, demonstrating that this affects our vulnerability system and the risk, vulnerability to disease. Here you have gender, age, and age. And here we have proportional universalism, what Michael Marmot always talked about, which is about that as we have this gradient, it's not only the poor ones, it's a gradient all over, so we need to have general activities for everyone, but in proportion to need. And here we have the theme for today, equal human rights, because if we don't mean that we have equal human rights, then we can stop this. So we must mean that we mean that. The good thing which has happened is that the very interesting thing that we had a very good dialogue between researchers, civil servants, and politicians. So all our recommendations are based on a common idea on the problem, the possible solutions, and recommendations. And I think that is why this is today rather embedded in the culture, and it is inserted in all the documents, striving documents in this region and also in local communities. And a lot of good things are starting to happen. But if, and here the important things happen. But as Lena is here, I actually wanted to have another metaphor, because we can do most things by ourselves here, but the way the state works can either raise or lower the threshold for us here. So if we instead say that the man here is the local community, and the state is the one who is taking the difficulties for the local community to work, with the help of legislations, taxes, etc., you can either make it easier or more difficult. So that's why we need you. We can do very much without you, but we need your support to help this climbing easier.
Thank you so much. Thank you so much, Margareta. Thank you. Give her a warm hand. While you take your seat and Lena takes your place at the table there, just preparing for your introduction, let me just ask you, Margareta, I think you have a very important message to everyone here. You know, in the audience here, you have people who are activists, experts on the national and local level. You have a lot of people who devote a lot of their time, both as professionals and in the free time, to promoting human rights. Mm-hmm. And you're telling them that awareness is extremely central to achieve equality in health. You need to be aware that there is a problem, as you were relating your own experience, you didn't think that we had a problem with inequality in health. What is your advice? What is the best way of raising awareness? Is it telling politicians about the economic consequences of not doing anything? Is it telling them about the great potentials of distributing health more equally? Or is it the moral argument to say inequality kills? There is a moral duty to do something about it. How would you argue?
I think three things. One is that I heard yesterday that people here had criticism that the theme for human rights was human rights for health. And how could they choose such a narrow item? Mm-hmm. And then when we discussed this, that it is about all living arenas, it is a very, very broad item. It's about life at all. And everybody of us can have effect on health if we are aware of the determinants. And each and every political decisions have effects on people's lives, either they want to know it or not. But the best way forward, I tend not to write articles in the paper and say politicians are stupid, because they are not. I believe in the trustful talk and dialogue, because that is the way we can together discuss and move forward. And we had a very good discussion on lunch together with politicians from all different colors. And everybody agreed that it is this trustful dialogue which is important.
Excellent. Thank you so much for this. Lena Hallengren, you made all your way here. You're Minister for Social Affairs in the Swedish government. You have the issues of popular health, folkhälsa, in your portfolio, but you're also responsible for issues related to people with disabilities. You are in charge of social services and many more issues on your agenda. You're extremely busy. We are so happy that you took your time to come here, and you also, as the others, have been giving painfully few but 10 minutes for an introduction. Please, Lena, the floor is yours.
Thank you so much. And I envy you all spending days together talking about human rights, and not least having the perspective also of the health issues. And let me also say I'm so very glad to be on the same scene as both Sir Michael Marmot. Actually, I think I was in the Social Committee in the Swedish Parliament 2013 when you were there. And I remember that you were not only just inspiring us, but also, I would say, opening up a discussion. Because as Margareta say, I think we all compare us to other countries, saying we're quite equal. Compared to other countries, we are quite equal, but we have lots of inequality, and if we don't see it, it will be just not possible to change anything. And Margareta, representing a region, it doesn't matter what the state does if the region's not doing their part of the job. So with that said, the growing gap between those who access the right to health and those who do not, it is both a pressing and also a present-day topic. Overall, I would say it's extremely important to invest in people's health. In people's health. Because investing in people helps improve the health of the whole population. It contributes to productivity, employability, and growth. Factors essential to sustainable development and resilience of societies in times of challenging environmental and social changes, and we need to really understand that the health is always a part of that. Public health in Sweden is developing, I would say, in a positive direction for the population as a whole. By international standards, as I said before, I would say the health of the Swedish population is relatively good. But Sweden's success rate in these areas is not a question of coincidence or pure luck. Improving public health has been an important objective for Sweden's post-war policy, I would say. There is a clear and a definite link between the development of Sweden's general welfare policy and its success in the area of public health. The general welfare policy is responsible for these positive effects and for the high life expectancy of the population and the very low infant mortality rates. But good health is not evenly distributed among the population in Sweden. Like in other Nordic countries, the disparities have widened over the past decades. Health inequalities has largely to do with the fact that people live under different socioeconomic conditions. That's very obvious. And for example, the remaining life expectancy at age 30 is 5 years shorter among both women and men with a short education than among women and men with a long education, just as Margareta showed at the slide before. And not only in life expectancy, but in areas such as mental health, ability to work a full working life, dental health, obesity and general health, the socioeconomic differences are apparent. And alongside health inequalities between different socioeconomic groups, there are also inequalities with other dimensions, such as gender, disability, ethnicity. Health inequalities remain disturbingly large, and in some cases, they're actually growing even larger. Groups with fewer resources, with less education, with lower incomes, poorer housing, and a fewer opportunities to influence decision makers, they have the worst health. Reducing inequalities contributes to social cohesion and breaks the vicious spiral of poor health and poor socioeconomic conditions. And to achieve this objective, however, a public health strategy based on a cross-sectoral approach must be pursued within all policy areas. Public health is increasingly decided by people's living condition and habits rather than by specific medical measures. And that welfare policy overall plays a crucial role in the health of the population. Public health is not only to be viewed as an objective and a result of welfare policy, but also as an investment in development. Good public health is important for the development of the whole society. It's important to achieve sustained growth, to achieve good welfare and ecologically sustainable society. It's absolutely essential to have a sound and solid knowledge of the measures that have a positive impact on public health. And it's therefore important that public health work is systematic, strategic, and long-term, and that it's based on the social health determinants that have the most influence on people's health. Thank you.
Thank you so much. A big hand. Thank you, Lena, and I think it must be rewarding for you, Michael, to hear that not only did you report last more than 6 weeks or more than 5 years, more than 10 years later, Lena still is here on stage talking about this, and we're all focusing our attention on how to close the gap in one generation. Lena, in your introduction here, you mentioned the importance of a general welfare policy, and you're talking about public health policy as something that has to be something that cuts across a number of different political areas. In the 10 years that have passed since the report, Sweden has undergone major changes. And unfortunately, income inequality and other measures of inequality have increased. And also there have been major changes to the way we organize healthcare with the introduction of a larger share of private actors. We have an increase in private health insurance. Now almost 1 million Swedes have a private health insurance. Are you worried that this might threaten health equality in Sweden, the fact that we have private actors that have maybe other incentives than doing the best for public health in their work? It's a big question.
Lisa. But actually, of course, I am worried if we don't have the common strength to really make sure that we have enough tax to finance the common needs for healthcare, if we don't have the strength to make sure that it's the needs rather than the knowledge of how the system is working, and the fact that you have the highest voice that makes you get what you want, also in the healthcare perspective. Maybe I'm not mostly worried about the private insurances for the moment, because still, actually, I think some of them are quite, they are fooled in one way, because they are paying twice. They are paying tax and they get access to the healthcare system, and they also have a private insurance which gives them about the same. But of course, if we're building this parallel system with the private insurances, it makes it easier for a government with another idea of how to finance the system. They're already served with an alternative, and that is, of course, nothing I want to see. So, but actually, I'm Minister for Health and Social Affairs, but I'm also a Social Democrat, and of course that is something which is, in this issue, talking about equal health, the possibilities for all, really noticing the fact that gender, where you live, your socioeconomic status, the parents' education, all of this makes huge difference. So even if you, on the paper, you have the same rights, that's not the fact, and that's of course something I'm always very, I mean, those are my glasses, of course. We have a very important reform of the primary care part of the healthcare system, which I think is very important to make sure that it's more accessible for everyone. But I'm optimistic, but of course we have parts of the system, and we have, I would say, also opinions, and the political climate, not only in Sweden, but in many countries, is not in total going in a direction making it more equal.
Thank you so much, Lena. I think it's important that you highlight that politics matters, and politics will be different dependent on the government. But you highlighted this morning, Michael, as well, that the way that inequalities in health will also in themselves affect politics. You were saying that health inequalities in the US were not caused by Trump, but they caused Trump. That these deaths of despair, the areas in the US where you have decreasing life expectancy because of the opioid crisis. People are literally dying at the rate that we haven't seen since the HIV/AIDS crisis at the height of that in the 1980s. Also causes a higher support for the kind of politics that Trump in a way represents. Do you see this threat to Sweden as well, if we have a situation where health is stagnating in some sectors of society? We've seen, if you look at the statistics from Folkhälsomyndigheten, if you look at people who have only secondary school, only högstadiet, but have not been able to qualify themselves to go to gymnasium, you have a stagnating health situation among that group. Do you think that this might have political consequences as well in Sweden? What do you think, Margaret?
I think it has very, very much. One reason is my research area, and my husband says too much interest, is in psychosocial factors and health, and psychological factors and health. And what we can see in all studies is that people's trust to other people is very hardly related to their socioeconomic situation. So the poorer you are, you less trust to other people and to organizations. And if we have increasing inequalities, this loss of trust, I think, is very, very dangerous. So I think we need to react before that has become too far. And one thing there, which I would want to speak to you now and maybe later, is that I have realized that the dialogue we had between politicians here in the region, where people are close to one another and we could sit down, tends to be more difficult when you come to the national level. And there are sort of silos between the different departments. We were visited by the school commission when we worked with the the Commission of Equity in Health. And they talked about the need that children should learn. And I said, what about their health? And they said, that's your job. We said, well, it goes together. Children who learn better feel better, and children who feel better learn better. And I hope that this has started a discussion, but I would wonder if it would be possible to have dialogue all over the political areas, because all people are wise to me, but people don't always have the knowledge. Also to see that the housing policy has affected people's health.
Lena?
Yeah, but really, I think actually, as we're working now with a strategy for public health, it's supposed to be cross-sectorial, but I would say that the biggest problem is that we have sectors within the ministries. I would also say that we have a political climate actually in Sweden, which makes the national level not a place for dialogue and discussions. And I mean, it's not. This is a long-term work. We're talking a generation. Politics is not even 4 years, it's maybe 3 years or 2 years, or maybe we have to leaving next week. I mean, that's not good for all the kind of important work you have to do, which is a question of, I mean, you have to give it time, because public health we don't solve that in a short time. So that is actually a problem. And also the fact that you really want to see the fast result, and you want to be the one with the best point, with most of the clicks on the social media. But actually, that is something which is making it more difficult for us to deal with those very, very essential and very difficult issues. So even if we're agreeing, talking like this, the next minute, it's more important to have that article published, or winning the votes, or whatever. So that is a problem for the work we're more used to, that we're working for many years. We're having investigations working for 5, 10 years to have ideas about a new preschool reform or whatever. We don't have time for that today, and I think that is going to affect us. Yeah.
So we have an increasing polarization of the political landscape and of the political debate, a problem with short-sightedness, of a lack of long-term perspective. Do you want to add anything to the possible political consequences of distribution of health?
Well, the first thing to say is I'm enormously relieved that your memory of my visit to this social committee accords with mine, and that you do remember it. And it relates to what we've been talking about. I was sitting in Cuernavaca in Mexico, and there were representatives from, I think, 6 different Latin American countries. And as we talked about which countries were getting active on the social determinants health equity agenda, it turned out that all the ones that were getting active had left of center governments. Now, how I vote is not the question. I'm delighted if the Social Democrats take this on. If you didn't take it on, who would? But it's pretty depressing to think. I mean, I've had senior conservative politicians in Britain say to me, well, your ideas really fit with Labour, don't they? And my response is, if you're saying that only a left-of-centre party is the only one that cares about health of the population, and the fact that people's health is worse than it should be through no fault of their own, then yeah, my ideas are closer to the Labour Party. But that means you really don't care. And if they say, we do care, but people have to look after themselves, now we can have a discussion, because I can show you the evidence that, I mean, I mentioned this morning that people in the bottom 10% of household income in England would have to pay 74% of their income to follow the healthy eating advice. So you can't say these people are being irresponsible. I tell a story in my book. Did I mention my book, The Health Gap? In The Health Gap, I'm concerned about the fact that life expectancy in the poor part of Glasgow is 28 years shorter than in the rich part of Glasgow. 28 years shorter for men. And I tell a story about Jimmy growing up in the poor part. I've subsequently read a book by somebody who grew up in that part of Glasgow, and it's very similar. Growing up in a family, single-parent family, a succession of male partners, each of whom were abusive, both to Jimmy's mother and to Jimmy, moving house every year, labeled as behavior problems by the time he got to school, involved in gangs. When he leaves school, no job, no skills, no qualifications, alternately hostile and depressed, doing drugs, alcohol and smoking. And you're going to say Jimmy's responsible for his own misfortune? If Jimmy had a stable family and a decent education, and he left school with good qualifications, and then decided to do drugs and alcohol and the whole thing, well, okay, at some level you could say Jimmy's responsible. So it's actually trying to use the evidence. And I know I am more rosy-eyed about Sweden than you are. I know I think Sweden's better than you think it is. But at lunch today, with the mayor and other of the local and regional politicians, at one point, fairly advanced in our conversation, saying, I didn't ask you which political party you were from. And it turned out there were about 5 parties represented around the table. Well, maybe you could have told. I couldn't tell which party they were. We were discussing the evidence of how you could make a difference. And once we can get that level of civilized discourse, where we might take different views of the evidence, we might emphasize different parts of it, but once we can have that civilized discourse, then my view is we can make progress across political party affiliations. But we've got a bit of a way to go before we can achieve that. They do it here in Linköping, but maybe not everywhere.
I think indeed maybe there was a rosy picture of everyone agreeing on these policies. I know that Lena is eager to have questions from the audience as well. She's traveled all the way here, and you have as well, and you have the privilege of being physically present. Does anyone have a short question? I know Josette is losing her. Yes.
No. One.
Patience with us. We don't have much time, but
no,
one question.
There are 2 questions
yes,
that I will read. It's a pleasure to meet you, ma'am. Welcome. Welcome. The first question is to your good self, Ms. Hellgren. The first question is to do with medicine and concerning deaths. In the United States, according to Bruce Lipton, iatrogenic deaths, which is death by medicine, is the #1 killer. Ahead of cardiovascular and ahead of cancer. Sweden has in many ways followed suit to the United States. Is there any statistics that measure the rate of iatrogenic disease in this country? That's the first part of the question. And if there are higher facts or facts available, why are they not available to us at this point? So that's the first question. Maybe it is your question and maybe it's one between you all.
Yeah.
Yes.
To be really honest, I wish I had a very good question, but I don't know really. I think it's a question of facts, but I think I could be able to find it. I don't think that's not, I think they exist, but actually I
Would
don't
you know,
Maybe,
Margareta?
Well, I'm thinking we are very concerned about quality registers and look at the quality of in different all specific areas, and also in safety systems. And here the use of pharmacy is coming in more and more. So I think it's in the system, but maybe not as public as it should be.
Thank you.
And knowing, yes.
Is that okay? Thank you. The next question, and this is for Sir Michael Marmot. You have shown in a convincing way that inequality, economic and social, is one of the main causes of ill health. How can that inequality be reduced or even eliminated? Would it help to go back to a really progressive taxation whereby the rich would have to pay more tax and the poor less. Would that be enough?
Let's take child poverty. And if you do a comparison where it's a relative measure, child poverty is defined as living in a household at less than 60% median income. Child poverty in Denmark is about 9.5%. In Finland, about 10%. Norway, 10.5%. Sweden, it's a little bit higher. It's not quite as low. But in the UK, it's just under 20%. And in the United States, it's 29%, just below Mexico. Now, we know that child poverty really damages children's life chances, not just while they're children, but for the rest of their lives. So then it's a matter of a decision. What do you want to do? I had a Swedish student in seminar I was giving, and she couldn't get over it. She said, some countries tolerate 29% of child poverty. I mean, it was so foreign to a Swedish way of thinking that a Swedish student didn't understand that some rich countries would do that. Now, I think present the data and then decide, are you quite happy with the regressive taxation that you have? I showed you the figures this morning of how regressive US taxation is. Is this what you want? You're damaging your children. You're getting crime in your cities. You're getting ill health. You're getting flatlining of productivity. You're getting all sorts of bad things are happening. And you could change it tomorrow. Is that worth doing? Well, I mean, if you say we don't care about our children, okay, that's a political decision. But then get up on a soapbox and say it very loudly. We don't care about our children. We're quite happy to see our children suffer. At least have the courage of your convictions if that's what you believe. But if you don't believe that, then stop lying and do something about it. And you can do it.
Thank you. There was one comment from your colleague. Did you want to?
Just a comment, because I think we need to realize that poverty does kill, also in Sweden. The quarter with the lowest income in Sweden have double the rates of hopelessness comparing to the richest. The suicide rate is double as high as in the low-income groups. But with that said, being said, and there is money in the system. We talk about high-speed trains. We throw bubbles in the air about billions of money. And this is one example. So we have money in other systems. So to me, I think it's important that we do invest in the welfare system, because we do have a law saying that the schools should be compensating for those who have difficulties. And that the welfare state is crackling in a lot of places. So I think we need to see how can we go back and reform these places and work in another way, so that we really can compensate, so that those who are not absolutely poor but only have poor families, difficult families, and are not very good at mathematics, etc., also can feel proud when they leave school and pride for what they're doing.
Is this one of the challenges you have in government, Lena? Convincing the other ministries we need more resources to tackle child poverty, because it has consequences for equality in health, for instance.
Yeah, but actually the question, does higher taxes solve the problem? Of course it doesn't solve the problem, but without more resources, and I would say, if we have any media here, they will notice this as a new new thing to say, because I think we need more tax money, and we can have it in different ways. We can raise the taxes, we can make more people working, and we get more incomes from the taxes. But of course we need more incomes, more resources, and of course you're right, Margrethe. Of course we can make another prioritization that is possible. My difficulty is not to convince the other ministers or the party we're working with. The fact is, and I'm getting back to that, I mean, we have a situation in Sweden with 8 political parties, with a government which is not in majority, and of course that is a problem in different ways, because if you're, I mean, of course you have to compromise, but if you're compromising in many different ways and you don't get the whole picture, I mean, I'm not a social democrat in just one area or with one specific issue. For me, that is a whole system. Being a social democrat means that we're having tax money, we're using it in different ways, but if I don't get all that tools and if I don't have the possibility to make sure that we have better benefits for the people unemployed, I mean, that will make poor children, because children are not poor, but their parents are poor. And how to change that, and we need a policy for that. So tax money is one thing, but how do we have a policy to make the adults in work not being sick and whatever? So the taxes is one important thing, but that doesn't solve the problem. You need to have the right policy, basically.
Thank you so much. I know that we have stretched our time, but I think that's a good ending line for all of us who are in here and who are listening, that we need to achieve a new consensus, and that has to be much broader than among us in here, and with Lena and her team and her department and also her government. It needs to encompass all the Swedish parliament to agree on the importance of trying to close these differences in one generation, to close the gap, indeed. Thank you so much for joining me up here, and thank you also to the audience.
A big warm applause. Thank you so much.